Good afternoon. My name is Glenda Hicks, and I'm one of the Born coordinators. On behalf of Born Ontario, I'd like to welcome you to our provincial rounds entitled Maternal Newborn Dashboard, or MND, 2-year update, looking back and into the future. A question and answer period will occur at the end of the presentation. Please type your question into the chat box in the lower left-hand corner of your screen. Feel free to enter a question at any time during the presentation. As you have heard, these rounds are being recorded and will be posted to the Born Ontario website. We're very pleased to have Sandy Dunn presenting today. Sandy is currently the Acting Scientific Manager and Knowledge Translation Specialist for Born Ontario. As a member of the Data Analysis Reporting Team, Sandy has been involved in the development and the implementation of the MND and other clinical reports available in the Born Information System that can be used to monitor quality care. Welcome, Sandy, and I'll now hand it over to you.
Thanks. Thanks very much, Glenda. It's my pleasure to speak with all of you today. It's wonderful to take some time to look back and reflect on how things have progressed over time. So what I'm going to do today is look at, because there may be listeners on the line who aren't as familiar with the dashboard as others are, I'm going to present a little bit of background information to give you some context to the reporting system that we're going to talk about. Then I'll present some trends that have evolved over time since the launch of the dashboard, and talk a little bit at the end about some future plans for dashboard development. So just some background. Those of you that know the Born Information System realize that data flows in from many different sources. There's the IVF clinic data, data from births from all 97 birthing hospitals in Ontario, midwifery data, prenatal screening results, newborn screening results, NICU data from the level 2s and some of the level 3s at this point, prenatal and newborn screening follow-up results, and we have some primary care data flowing in as well. The specific purpose of this slide today is just to highlight that the Maternal Newborn Dashboard reports uses data entered by hospitals for births that occur, and it's been designed as an audit and feedback tool to be a resource for those hospitals. So the Maternal Newborn Dashboard, as I said, it's an electronic audit and feedback tool. It was designed and is designed to help hospital users, labor, birth, and postpartum units within hospitals identify areas where practice is good and where there may be room for improvement. It compares performance on 6 key performance indicators that were selected to populate the inaugural dashboard 2 years ago when this was launched. Evidence-based benchmarks have been set associated with each key performance indicator, and there's also comparison data. This is a tiny picture on the right. I will show you a bigger picture in a little while, but that's in essence the homepage picture of the dashboard, where you see the key performance indicators listed on the left, obviously in font you can't read. A rate, the hospital rate is next. The circle signals are the signals that are set and determined based on the hospital rate compared to the benchmark targets, green, yellow, or red. And this resource has been designed as a tool to help users better meet their quality mandate as set out in our Excellent Care for All Act, the legislation that was published in 2010. So the Maternal Newborn Dashboard was launched November 19th of 2012, and we'll be looking at a 2-year window since then when I get to the slides that report on results. So the dashboards in practice, both in healthcare and outside of healthcare, have been used quite a bit. And in healthcare, they're designed to be a catalyst for quality improvement. This little model that you can see that is the sequence of rectangles in the arrow highlights the 2 first steps towards quality improvement. Is first being aware there's a problem and having evidence and information to help the team come together to agreement about the direction they need to take and the strategies that are needed to put practice change in place. So Born has a dashboard development process. It's been used for the development of this dashboard, is currently being used for the development of 2 other dashboards that I'll talk about at the end. This paper that's cited here describes the process. I won't take time to go into it in more detail, but anyone who's interested can go and pull that reference, and you can read a more detailed description of what we went through to develop this dashboard. But in essence, the key performance indicators that were selected have all been deemed to be clinically meaningful, feasible to measure, and amenable to change. They're important for quality care for our mother-baby population. So in conjunction with selecting the key performance indicators, setting the benchmarks, the expert panel of clinical advisors that we worked with across the province helped to set the benchmarks select the KPIs and select the benchmarks for each of the KPIs. And during that process, evidence summaries were developed for each of the KPIs. The ones that were developed for the original maternal newborn dashboard have been posted on the Born website. They're available to anyone because we also wanted to use those as a resource for clinicians, not only for the development team, but as a resource for users in the end. So those are available. This is just a little print illustration of one of them. And so before we move into looking at results, I always like to bring up the Ian Graham's Knowledge to Action cycle, which you can see here on the right of the screen, illustrates the creation of knowledge products and tools going from primary empirical evidence, primary studies, research studies that are then clustered together and synthesized as more research becomes available, where systematic reviews are done, and those systematic reviews can help inform the development of best practice guidelines. And those knowledge tools then are useful, if available, to help clinicians, policymakers, and decision makers identify practice gaps. And the red circle on this diagram is really the target area of this knowledge to action cycle that the dashboard is designed to help users with. So the evidence summaries that have been created, the data from the Born information that users put into the system that we now can use to generate information for users about their hospital practices, help hospitals then identify whether their rates for the performance indicators on the dashboard are in alignment with what best practice suggests it should be. If a gap is identified, then the outer part of the circle represents the steps, the practice change steps, quality improvement steps that would need to be put into place and evolve through in order for improvements to occur. So we aren't going to focus on that today, but I just wanted to highlight really the benefit, the value that the dashboard brings with the information it provides and how it can facilitate quality improvement. So a few brief slides. This is a bigger picture just to illustrate some of the reporting tables available in the dashboard for those of you that might not have seen it. So all authorized users who have a password and have been approved by their own organization to be authorized users of the Born information system, either to enter data or run reports and pull data out, would be able to log on to their Born information system. And on their homepage, they would see their hospital's dashboard and the signals and rates associated by the population captured in each of these key performance indicators. And so as you saw in the tiny little picture, this one's a little bigger, may not be able to read the writing and all the numbers, but I think you can get the idea. The key performance indicators are on the left. The hospital rate is next. The signal associating the hospital rate with the benchmark rates listed in the green, yellow, and red columns. And then the comparator rates that are provided for everybody are their peer rates. So a level 1 hospital would see an aggregate rate of level 1 hospitals presented, would see an aggregate rate of similar hospitals with a similar volume of births to theirs would be in the next column. And the final column on the right is the overall Ontario rate, and that's what everyone would see. Users can then drill down from this screen to a data table. Again, this is totally a sample table for illustration only, but the highlight points that I wanted to make here is that we then try to provide enough information to give hospitals a place to start to explore the practice issue through auditing. So this table gives them the numerator, the denominator, the rate, color-coded, exactly the same match as on the previous screen. So if your rates for a given period were red on the previous screen, it would be coded red on this table. We give confidence intervals, highlight missing data, and also illustrate for the comparator groups the aggregate rates, how many of the peer organizations in that aggregate group have acknowledged their data. Data is generated in the dashboard based on a rolling quarter of data with a 1-month lag so that we have sufficient sample size to try to stabilize the point estimate over time for the small hospitals with small birth volumes. And we need acknowledged data in order for the reporting system to use the data that's entered. So acknowledged data, so for example, in here it says at the very bottom, October 2012, the first comparator group of other neonatal level 2 hospitals, 3 of 16 have acknowledged. So a user would be able to say, okay, well, not very many of my peers have acknowledged yet. That may not be a very reliable rate as a comparator. We'll wait for a little bit longer and then see. And the other point to note is that, as you can see, rates are reported by fiscal year. Hospitals can then drill down by quarter and by month to get more detail and track their progress over time, whether it is to just watch where they're at with a key performance indicator, or in fact to monitor progress if they're implementing some quality improvement. Organizations can then drill down to an audit table. It doesn't show it in this picture, unfortunately, but the numerators, which are in the second column over, so I'm not sure if you can see my mouse. I'm trying to scroll here. But if you look at 208, 208, 88, 29, et cetera, these are the numerators, and those are hot linked to a data table that looks like this. So if you clicked on one of the cells on the previous table, if you clicked on September 2012, 29, you wondered what those 29 cases were, then you could go down, and this isn't a match with that, but you would get a list of the chart IDs that were used, that the system recognizes belongs in the numerator for this key performance indicator based on our inclusion-exclusion criteria. And then users can hot link on the chart ID number, and that takes them right down into the record level data they've entered for the system. So if there are revisions to be done, if there's additional data that needs to be added because of missing data, that we give them a place to start to begin the process of auditing. Some of the key performance indicators also include a sub-report. For example, if there are insufficient or unsatisfactory samples for newborn screening, there is a table that provides information about the reasons for why samples were rejected and considered unsatisfactory. So a site can go and look at the cases captured in the numerator for this KPI and be able to get a feel for what types of criteria are they not meeting as a place to start to explore the issue in their site. And then this is another KPI that happens to have a similar type of information. It's KPI 3 for formula supplementation at discharge. And it includes reasons for formula supplementation. And so it's, again, just an illustration that we have tried to think of ways to provide additional information to organizations when they look at the rate. The signal they receive on the dashboard is just a signal. It's either red, that's a warning, or yellow, or the green that you've reached the target. And the yellow is to flag an issue, start watching it, and red is the suggestion that there's something going on you need to investigate further. It's simply an alert. It doesn't tell you why things are happening, but we've built in these reports to begin the process for hospitals to help to audit. So having said that, I won't belabor the background anymore. For those of you that are familiar with the dashboard, thank you for your patience as I went through that. I just wanted to give those who might not have experienced the dashboard or participated in these presentations before to get a flavor for what they look like. So now what I'm going to do is present for each key performance indicator 4 different slides that show data in a different way. They will all present for the same time period, January to March 2013 to January to March 2015. And remember, I said the dashboard launched November 19th of 2012. So January to March 2013 is the very first quarter after the launch, recognizing the fact that probably from the 19th of December to the 1st of January, likely very little happened, so that we can really look at this first quarter of this particular time period as, or in fact, this was the last quarter of the 12-13 fiscal year, as the beginning. So for KPI 1, and I'll talk through these 4 slides in a little bit slower, just to give you your bearings. Then we'll be able to go through the other KPIs a little quicker. So the first slide for each KPI will present the rates by LIN. In this format. Again, I apologize for the small font. I've made it as big as I can while keeping it on the slide. Don't worry too much about the numbers. I'm hoping that's not going to fuss people too much. But to give you bearings, again, each column header is a quarter. So from January 2013 to March 2013, all the way over to the most recent quarter, January-March to March 2015. The LINs are listed on the left-hand side. You will see the order in which they're listed changes for each KPI and for each slide, simply because of the fact this report that was designed puts them in sequence to put the most improved to the least improved for the given time period we're looking at. And for this particular time period, the absolute improvement is calculated by comparing the first column, January to March 2013, to the last column, January to March 2015. It does not mean that change didn't happen and improvement didn't happen, and some LINs had more improvement during different time periods. They did. You can see that there's a lot of fluctuation in just the color coding of the cells, which has been added to the graph so that it illustrates. You don't have to worry about the numbers so much, but the color coding matches the alert, target, warning, and alert numbers at the top. So for those of you from different LINs, you'll be able to pick out your LIN. But the most important take-home message here, you see the LINs down the left. Ontario is always the last row so that you can see the overall Ontario rates for. So for KPI 1, the Ontario rate at launch was about 2.2% of submissions to newborn screening resulted in unsatisfactory samples, and we're now down to 1.7, so we see green across the province for that. So for the most part, there has been some fluctuation, certainly mostly yellow and green now, so it appears just visually with the colors, although we recognize that all LINs are not equal. There are larger hospitals, smaller hospitals. Some have more hospitals than others. So this in no way, shape, or form is intended to suggest that this is an equal representation across all LINs. It's just one way of presenting the data by region. So this is the first slide, and you'll see this replicated for each of the KPIs. The second slide takes the same data but presents it by level of care. So it's the same quarterly breakdown across the 2-year period, the same. So the level of care hospital sequence is juggled depending on which level of care grouping. The aggregate rates from which level of care grouping showed the most improvement over time. Less relevant for this perhaps, but interesting to see whether there are little pockets where issues seem to fall more with respect to levels of care if you look where the red and the yellow are populating. Again, Ontario was always at the bottom of the row, and the Ontario numbers are the same for both of these. So the third slide for each KPI will be a box plot, and this was just because the previous 2 slides are reporting by groups, so LIN groupings or level of care groupings. the box plots have been prepared to present the hospital level data to cluster looking at all 97 hospitals and where they fall. So for those of you familiar with box plots, this will make sense to you. For those who are not, I'll just describe for this one. You'll see that there's a long tail on the right-hand side, a box, and then a tiny tail at the bottom for both of these displays. The one qualifier I'll need to make, and I do apologize, these box plots actually were not created with the same 2-year span, so we won't have the benefit of seeing the movement of the whiskers and the box over 2 years. I had thought they were, but they weren't. So you'll just have to bear with us on that. There still is some information we can get from these. So the box contains the middle 50% of the 97 hospitals. The top whisker represents the top 75 or the 75th percentile, the top 25 hospitals, and the bottom whisker represents the bottom 25 hospitals, or the reverse, depending on whether we're talking about a positive or a negative KPI. The line, which you don't really see in this, but you can see on the illustration over at the right, when you are able to see a box that has a line in it, that's the median rate across all 97 hospitals. And then we've added the numbers and tried to add some arrows to reflect what the hospital groupings are within each of these. So for the most part, you can see the majority of the hospitals fall within the yellow and the green, and that's really what our tables, the previous tables, showed. So the next slide that I've prepared for each of the KPIs is really taking all 97 hospitals, anonymizing them, because we can't present with hospital name at this point. That's why we present with aggregate data. But we are able to present the 97 hospitals anonymized. So we took those and created bar graphs for the two specific time periods, the beginning and the end of our 2-year time period, January to March, just to give you a sense of the dispersion of the rates across the all sites for the 2-year period. So the first graph on the left represents the January to March 2013, and you can see there's wee bit different dispersion. You're seeing some movement here. And the green line and the red line I've tried to add as closely as I can with these small graphs to match the target and the alert levels on the benchmark rates above. You will see that. So you can certainly see that there's a good proportion of hospitals that are achieving green, certainly some that are in the yellow, and then a proportion of hospitals that when you get down to the hospital level, although rolled up in the LIN level, we didn't see it so much. There are definitely still hospitals that are working on getting below the red level. So this is KPI 1. In summary, I have a little summary slide. For the most part, I have said this, I believe, but just to reiterate, we have seen progress. We've seen about a 0.5% decrease across the province since the launch. We now have 7 of 14 regions. If you look at the LIN level in the green, we know 19 hospitals have moved from a yellow or red signal to achieve green since January to March of 2013. And it, of course, translates into incredible savings and issues for parents and babies. So that this is suggesting that, at the very least, it's a useful tool to help hospitals become aware of whether they have an issue or not that needs some exploration. So now we'll just do the same sort of sequence. You'll be oriented to what the slides are. So we're going to look at the other 5 KPIs and see whether we notice change in colors and movement at all. So this is KPI 2, which is the rate of episiotomy in women who had a spontaneous vaginal birth. And you can see actually across the 2-year time, it looks pretty green, rolled up to the LIN level. For sure, with one area still working on some improvements. And the provincial rate dropped from 10.3 to 7.4, with the target being 13. So even though the overall provincial rate has been green all along, there's still been some improvement with the rates dropping even lower. So episiotomy was, based on this, was being done fairly well. This is looking at the same KPI, but at the level of care breakdown. Again, predominantly green all over when you aggregate up to that level. Here's the box plot. You can see certainly, even though we don't have the 2-year spread here, we essentially have most hospitals, well over 75% of the hospitals in the green. A few are yellow. Just one caution I need to bring to your attention from KPI 2 onward, that the January to March rates are based on all hospitals that have acknowledged data of the 97, and that there are 20 hospitals that have not yet acknowledged. So we are reporting this quarter because it falls below our 30% threshold of needing no more than 30%, or we want less than 30% of sites to have acknowledged to start reporting. But recognize we have some unacknowledged sites that will potentially influence what these rates look like ultimately, and whether or not in those 20 hospitals that haven't acknowledged, they could fall within the red, they could fall within the yellow, or they could fall within the green. We don't know. But at this point, this is what the data is showing. And so here's the episiotomy KPI number 2, looking at dispersion by hospitals for the rates in those 2 time periods, the beginning and the end of our 2-year time period. And you can see the configuration of the curve is changing slightly, with most of the organizations, when you look at the site level, falling within the green target zone. And so, again, conclusions: generally good rates across the province. Most regions and level of care are green. Practice has improved slightly in the 24 months, even though it has been generally good. We've talked about the overall provincial rate dropping. And then finally, 10 hospitals in that 2-year period have moved from a yellow or red signal to achieve the green benchmark. So definitely, even though practice was good, we've seen improvements as well in this KPI. So KPI 3, moving on, and I'll just read the title first. I should do that. Rate of formula supplementation at discharge in term infants whose mothers intended to breastfeed. And so here's the LIN level table. At the beginning, at launch, the Ontario rate for this KPI was 33.5% of babies who were full term, whose moms intended to breastfeed, were supplemented in hospital. Now down to 31.4%. You can see, if you look along the bottom row, rates have actually dropped even below that, but it hasn't been sustained. So April to June of 2014, the rate was 28.7 across the province. So there certainly is fluctuation. There is movement, but fluctuation. So we now see we have 3 LINs that are achieving the target rate, a couple that are falling yellow, and others still working on this initiative. Here's the level of care groupings with the level 1 hospital groupings falling green, the other hospitals still in the red. Here's the box plot that shows you the box and tails. So still a proportion of the hospitals, 25 of the reporting hospitals, is still in the red. Some of the 14 hospitals that fall within the box are red, yellow, or green, and then 30 are falling in the green zone. So that gives you a little bit of a feel for the dispersion across hospitals. And here's the look at all the hospitals that we have acknowledged data for in the 2 time periods, and the dispersion of the curve and where the green and red lines fall. So we can see movement for sure, but still certainly some challenges hospitals face in working on this key performance indicator. So we've seen a 2.6% decrease overall in supplementation rates across the province. 13 hospitals have moved from yellow or red signal to achieve green since January to March of 2013. We know, or many of you will know, the Baby Friendly Initiative strategy for Ontario, funded by the Ministry of Health and Long-Term Care, was launched October 2nd of 2014, and this BFI strategy will provide hospitals and community health organizations with training, tools, guidance, and educational resources to help achieve the BFI designation. Toronto East General is leading the strategy with Linda Young at the helm, and they are in partnership with the Provincial Council of Maternal Child Health and Best Start Resource Centre at Health Nexus are working to lead this. Bourne's collaborating with this group, and we have gone through the process of revising breastfeeding data elements to align with current definitions and the BFI indicators. And actually, on Tuesday, we launched a new and updated report that was specifically designed to be able to report rates related, many more detailed rates related to breastfeeding indicators. So we hope that movement across the province, this initiative and the momentum that is energized by this, we will have the dashboard and the BFI reports to help organizations monitor their progress. So the fourth KPI, which is elective repeat cesarean section, performed before 39 weeks gestation among low-risk women having a repeat section at term who are not in labor. And so here's the LIN level graph looking at the colors across time. So we do have one region that has seen improvement, is now sitting green, was green 3 quarters ago, was yellow, back to green. Another KPI or another LIN in the southeast also making progress, and the LIN 8, central LIN, is making progress. Having said that, the rates when the dashboard was launched was 47.9% across the province. Overall, the provincial rates are now down to 33.3. So even though you see a lot of red on the graph, there is still movement in certainly when you aggregate up at the LIN level, but also when you look at the work that individual hospitals are doing to explore, address, and tackle this important issue. So when you break it down by level of care, again, still all red, but the same message, progress is being made. And there you can see the box plot. So we still have a significant number of hospitals sitting in the red, 3 reporting yellow, 19 now in the green. With the box in the middle, the 50% in the middle, the variability in rates across those 50% tightening up. And there's the dispersion with the individual hospital level graph presenting individual rates in a dispersion curve. So quite a few hospitals still exceeding the red, but you can see the curve is shrinking on the right, that it's becoming more concave. The rates in the center of the pack are beginning to inch down. So highlights here, I think I've probably mentioned this, the fact that the rates are evidently moving. Since the launch, we've seen a drop in 14.6% over the province from 47.9 to 33.3%. We've seen 11 hospitals have moved from red to green, and 2 sites have achieved a yellow score. Although it's slow progress, we know there is movement and momentum. When there's a long way to go, it takes time, though. And so KPI 5, proportion of women delivering at term who had GBS screening at 35 to 37 weeks. There's the LIN level graph, quite a significant change in colors over the 2 years, so that although we're not all in the green at the LIN level, certainly there's a significant amount of green where there was none at all when this dashboard was launched. So Ontario rates have increased, and this indicator is designed the reverse. We want the rates to be higher so that there's more completion of screening. So the provincial rate was 86.8 at the launch of the dashboard. It currently is now in the yellow warning zone, although improved, and it's sitting at 93.3 across the province, with 7 regions falling in the green. The one caveat to this that I will say that upon request from users, one additional pick list choice was added to this KPI data element for GBS screening, and that was mom's declined screening, so that cases where mom's declined screening are excluded are possible to be excluded. Numbers are not massive by any stretch of the imagination, but it does allow for sort of an improved inclusion-exclusion criteria. So there's the level of care breakdown, where you can see the neonatal level 1 groupings seem to still be in the red, and the level 2B still in the yellow. There's the box plot, so it's just the reverse. We can see 14 sites are still sitting in the red, 11 are yellow, and 44 are sitting green of those acknowledged sites. And there's the dispersion across the province. So practice, although there were some improvements needed, was pretty good to begin with, and we've seen improvements slowly progress over time. We can see the curve changing a little bit here. And I told you about adding the pick list choice decline GBS screening, and we now see that 7 of 14 LINs are green, and overall across the province, the rates have improved by 6.5%. And so the final KPI, and this is the final series of slides looking at results, is reporting on proportion of women induced with an indication of post dates who are less than 41 weeks gestation at delivery. And here is the LIN levels table, again predominantly red when aggregated up to the LIN level groupings, with one region making progress and has achieved green, another region slipping into the yellow zone for this most recent. Always remember this final column, we don't have full reporting. 20 of the hospitals across the province have not yet acknowledged. So where those hospitals lie, whether they will bump other regions up into a yellow or a green zone, or will stay within the red, we don't know. But at this point, this is what the picture looks like. We see Ontario's rate for this indicator at launch of dashboard was 25.8. It has now fallen to 16.8. Although it's still in the red, it certainly has improved. And there's the level of care view, again with one of the level 3A and 3B grouping, aggregate groupings with the most improvement. There's the box plot to show certainly some tightening of the 50% group in the box with narrower rates, and the median has fallen. So we have 25 green, 6 yellow, and 38 still in the red who are reporting at this point. And there's the picture of the dispersion across all of the hospitals, again with more concave curve on the right-hand graph, so the rates are slowly coming down, even though there's still some considerable work at the hospital level to achieve the green. So the summary for this, I believe I've already said, so we'll just move on to the next few slides, where I've taken a little bit of a different look at some of these KPIs. So you can't read this at all. It's not the numbers or the words. I put it here just to give you, this is a dashboard at the provincial rate level. So this is just taking the provincial rates, the same 2-year span from January to March 13, January to March 15, and looking at the color signal over time so that you can see for KPI 1 and 2 over time, the province is now sitting green. So that's the unsatisfactory newborn screening samples and episiotomy. You can see KPI 5 across the province is now yellow and has been for some quarters, and that's the GBS screening KPI, and then supplementation, elective repeat cesarean section, and the induction KPI 3, 4, and 6 are still red across the province. So this slide just shows you, I took the tact, although there are many, many ways to look at what would we define as progress. I've taken the tact to look at the number of hospitals that at launch were red or yellow and are now 2 years later at this most recent quarter are green. And so this graph just breaks down each KPI with those two end point quarters, 2013, 2015 quarters as comparison, and looks at the number of hospitals that are green, were yellow, were red. And we can see for KPI 1, although there's been improvement, 53 hospitals were green at the start, 53 hospitals are still green. They aren't necessarily the same hospitals, but the numbers are stable there. And so this just gives you a little bit of an idea of some of the variability and some of the progress that's made, and some of the reduction in numbers of red sites. The black columns that you do see from KPI 2 to KPI 6, you don't see it for KPI 1, and because KPI 1 does not require acknowledgement. This KPI is rates are generated based on a direct lab feed from Newborn Screening Ontario, so we don't need data acknowledged. But for all of the other KPIs, it's based on data entered at the hospital level. And the black bar it reflects the 20 sites where we don't have acknowledged data. And so this black bar, eventually when this data is acknowledged, will either fall, those sites will fall within the green grouping, the red grouping, or the yellow grouping. So this gives you a little bit of a different look. This is looking at the number of hospitals that, again, the same 2-year time period, the beginning quarter and the end quarter, that improved from red or yellow to green by KPI. So for KPI 1, 9 hospitals were yellow at the start, and they're now green. That's the yellow bar. 10 hospitals were red when the dashboard was launched, and they're now green, for a total of 19 hospitals that were either yellow or red and are now green. And that's exactly what the subsequent bars reflect. So for KPI 2, 10 hospitals were yellow or red and are now green, et cetera, et cetera. 13 for KPI 3, 16 for KPI 4, and a whopping 32 organizations at launch were either yellow or red and are now green. And then you can see KPI 6. So a little bit of a different way to look at the data. And this is a slide that looks at the number of hospitals that have improved. And again, it's just a different way of looking at the same numbers as the previous graph. So for KPI 1, 19 hospitals moved, and it's just the color phase in these bars does not reflect numbers of hospitals. It's just my attempt to try to illustrate the movement from red or yellow to green. And so it shows you KPI 5 had the biggest improvements. KPI 1 came second with 19 hospitals moving from red, yellow to green. KPI 4 and 6, those ones that seem to be predominantly red for us quite a bit, were tied with 16 hospitals now distinctively in the green. And some of these hospitals have been green for some time. It's not just this quarter, albeit some of the hospitals reflected in this graph have just moved into the green zone. And this final slide is then taking this idea, this group of 65 hospitals in total that have improved from being red or yellow on at least one KPI to green, and where was the biggest movement. So 36 of the 65 hospitals improved in just one KPI, which is no small feat. I don't mean that to be negative. 18 hospitals of the 65 actually improved in 2 KPIs, and 11 hospitals improved across 3 or 4 KPIs. 10 improved in 3, and 1 hospital has managed to achieve green in 4 of the KPIs, having started when we launched 2 years ago to be yellow or red. So I think an indication that something is going on. And this is essentially what I've just said, so I'm going to move past this slide in the interest of time and making sure we have time for questions. So overall, we've seen what appears to be improvements across all the KPIs, even the KPIs that were relatively green to begin with. And we know from anecdotes from hospitals who have made improvements, they're using their dashboard to trigger quality improvement. They're watching it. They're logging on and tracking rates. They are auditing data if there's questions. They're improving data capture, both the timeliness and the accuracy and completeness of the data. They're using the sub-reports to help them do audits and get a feel for why their rates are the way they are. They're meeting regularly. They're involving their interprofessional team to discuss strategies for improvement. They're looking at the barriers and facilitators specific to their own organizations, resources, and practices, and they're developing tailored strategies that work for them to influence change. And although change takes time, they are certainly moving ahead, setting targets and tracking progress. And some, the really brave ones even, are sharing their data publicly. And what we hope to do at Born, and we have done before and will continue to do, is to try to provide venues where organizations who will want to share their story and have successfully tackled some of these practice issues, we are more than happy to provide webinar time through Born Provincial Rounds, through networking and connections with different hospitals, through profiling their stories in our bulletin to share the word so that other hospitals who would like to be able to learn how organizations have addressed change, how they can move forward too. So our next steps, this is just the final couple of slides. We will definitely continue to monitor the use of the dashboard and practice related to the key KPIs. We have CIHR and Ministry of Health and Long-Term Care funding support to evaluate use and effectiveness of the dashboard to improve practice, and we have already reached out to many organizations to recruit and request participation in getting feedback on their experience with the dashboard and how they used it and what they were able to do, or for improvements we need to be aware of so we can use that information to help move forward. We are working with different stakeholder groups and our maternal newborn outcomes committee and clinical experts across the province to look at potential new KPIs for the current dashboard and determine the best way forward, thinking of recognizing the fact that this is an opportunity and a resource that can help bring to awareness for organizations practice gaps that may exist, so to align with current other provincial initiatives that may be underway. I've talked about sharing success stories. We always are available for support. Our Born coordinators, tremendous group of women who are available and are in the field working with the different organizations within their geographic area to provide support for quality improvement and help with data entry and data out questions. And I know they are all available for continued work, as we all are here at the DART team at Born, the report development and the analytic team. And we're working with development of 2 new dashboards. And here are some examples. The fertility dashboard, the fertility stakeholder group has selected 6 key performance indicators that are clinically meaningful and important and feasible to measure and amenable to change. We've just completed 2 evidence summaries for the first 2 that eventually will be built into a dashboard that will go live sometime in the future. And we're working with an NICU stakeholder group and our dashboard development committee to consider a number of KPIs. That this is not final selection, but this is an example of the 4 that are on the radar right now. So whether they actually make the cut and make the dashboard is yet to be decided by the group, but this is an illustration of what's being worked on. And so our conclusions, ultimately, we know practice change is complex. We know good decisions require good data, so garbage in, garbage out. It's so important to put the efforts into getting data in that is meaningful and will be of use to you as you monitor change and try to identify practice gaps. We know the usefulness of the dashboard as a tool to guide decision-making is really dependent on organizations getting complete, accurate, and timely data into the system, so their level, their site, and comparator rates can be generated. We can only use what we know, and so access to and interpretation of data is key, and therefore working at the site level to look at what their rates are and audit and explore the data and the cases captured in these key performance indicators is the place to start to figure out, along with exploration of their practices, whether there are system changes that need to be put in place. We know dissemination of information is necessary, but it's not sufficient. Communication and education is necessary, but it's not sufficient to address practice change. Practice change needs multifaceted, tailored strategies designed specifically to target the barriers to change and the practice issues, the triggers that are causing the practice issues to begin with. And as well, sustainability is important, and that's one thing that we also hope that the dashboard will be used for over time in the future, not just to identify a practice gap, but to help organizations with quality improvement and to monitor and evaluate their progress over time and the sustainability of the practice change once put into place. And so my last slide, I will close, but before I do, I cannot close without acknowledging the tremendous work of a fantastic group of people who have made this whole project possible. Certainly to the hospital users who enter their data and use the reports to guide and monitor practice and help us understand how to do things better, how to improve, and how to support them. And to all the Bourne staff here, the coordinators, the report development team, the data analysis reporting team, and the tech team and DAPASoft people who have made the development of dashboards possible. And of course, to CIHR and the ministry for funding their funding support for the maternal newborn dashboard study that we are going to learn so much from that will help all of us in the future. So thank you very much for listening. I hope some of the information has been useful to you, and I'm happy to take questions for the last few minutes if there are any.
And just a reminder, if you have any questions, please type them into the chat box. You can access the chat box found on the bottom of the left-hand side of your screen. There were 2 questions in queue, Sandy. The first one was pertaining to hospital users. Would they be able to access LIN performance reports? And that question came from Cornwall.
I'm not sure I know what you mean. Do you mean if you mean the LIN level tables? Well, they would be able to access them because these, of course, are how we present the data, and they're in our slides and certainly available to anybody who wants to share them. The LINs don't have access to the Bourne information system. They do request data from us, and sometimes they request data about the hospitals within their LIN, and sometimes they request data based on provincial rates or other LIN comparators. So in that way, they would be able to learn about where their LIN stands. I'm not sure I've answered the question, but
yeah, she just responded. Sorry, I'm referring to the information you were displaying,
okay.
And you've also responded to the will the LIN have access to this dashboard?
Okay.
And there's another question in queue, and it's just wondering when the reports will be reflecting midwifery stats, both for home births and for data from the 2 birth centers.
Yeah, good question, Teresa. There definitely is interest to develop a midwifery dashboard if one was deemed to be meaningful and useful to the midwifery practice groups. This particular dashboard was designed for hospital births. Some of those births would have been attended by midwives because it's just a composite of births that happen in the hospital. So a dashboard specifically focused on and reporting on only midwifery births is not underway yet, but not something that's beyond the realm of possibility. But I would just point out that when dashboards are developed, they're developed very specifically around the user groups for which they're designed and the practice, the clinical context in which practice is provided, as well as based on evidence specific to that clinical context. So midwifery key performance indicators would need to be very specifically designed around midwifery practice, best practice guidelines, and performance indicators that were meaningful for those populations. So when, I can't say, within the realm of possibility in the future, without doubt, it's just a matter of interest and time and working with the groups.
Thanks, Sandy. And there's another question, just to respond again, if you don't mind, to the will the LHIN have access to this dashboard?
So what I said was the LHIN does not have biz access privileges. In other words, they can't log on to the Born Information System because it's a hospital user or a midwifery practice group user that actually enters the data. Those are the users who have access to the Born Information System with respect to the hospital births. So the LHINs cannot log on and run their own reports. Having said that, though, data that I have presented today, which we often use this type of format when we present, is available to the LHINs. The LHINs also can request data from Born in whatever form is useful to them, and so sometimes they ask for LHIN comparators, sometimes it's provincial rates, sometimes they would like to know specifically the breakdown by hospital within their region, and so they don't literally come and access the Born Information System to run reports, but they obviously have interest in data that reflects performance of hospitals in their region.
There are no other questions in the queue, so just a reminder, if anyone does have a question, please feel free to type it into the chat box, just in case somebody's got a lingering question. Well, thank you, Sandy, for an excellent presentation. It seems that no one else has a question at this time, so thank you for the review of the Born Maternal Newborn Dashboard, the presentation of KPI trends, and outlining the future plans for dashboard development, all of which has been really exciting and provided a really good overview looking at the dashboard to see since inception how trends have changed. So thank you once again.
My pleasure. Thanks very much, everyone, for signing on and listening.
And one final announcement, we'll be taking a break from Born Provincial Rounds for the summer months of July and August. We look forward to resuming the rounds in September, and you will receive notification, as is our usual practice. Thank you again, Sandy, and thank you to everyone for your time and for your attention. Bye
Thanks,
for now.
Linda. Bye now.
Thank you.